Hello friends, this is Dr. Sunil Kumar Ahuja. Welcome back to Brain and Disease Corner. Today I will be teaching you drug mirtazapine. So let us start. Metazepine is a atypical antidepressant. It treats the depression. If we see its biochemical structure, this is the biochemical structure of the metazepine. This structure shows metazepine has the four rings: first, second, third, and fourth. Out of four rings, two rings belongs to the piperazine compound. So this is the separate picture of the piperazine compound, which consists of the piperazine ring and the azepine ring. This piperazine ring has the two nitrogen molecules embedded in the benzene ring, and azepine group has the one nitrogen molecule embedded in the heptide ring. So azepine ring has the heptide ring in which one nitrogen molecule exists, whereas piperazine has the two nitrogen molecule embedded in the one benzene ring. Metazepine is a tetracyclic ring, belongs to the piperazinoazepine group. Now coming to the salient features of the metazepine, that is the features which differentiate the metazepine from other antidepressants. This table shows that metazepine has certain advantages and disadvantages over other antidepressants. Right column of this table shows metazepine does not cause insomnia, it doesn't have any sexual dysfunctions, and also metazepine does not cause GIT related side effects like it does not cause nausea, vomiting, loss of appetite, and dyspepsia. This middle column shows metazepine is a weak antidepressant, that is, metazepine is a weaker antidepressant as compared to the other antidepressants. In contrast to other antidepressants, metazepine does not act on the transporters, albeit it acts on the receptors, and thereby it increases the level of the serotonin and other monoamine neurotransmitters. This is the icon of the metazepine, which shows metazepine acts on the histamine 1, 5-HT2C receptors, 5-HT2A receptors, 5-HT3 receptors, and alpha-2 receptors. But remember, metazepine directly does not act on the 5-HT1A receptors. Actually, metazepine blocks all these receptors. So, metazepine is an antagonist at alpha-2 receptors, H1 receptors, 5-HT2A receptors, 5-HT2C receptors, and 5-HT3 receptors. Metazepine has the therapeutic effect and side effect by blocking all these receptors. For example, by blocking the H1 receptors, metazepine causes sedation or hypersomnolence. It causes the increase in appetite and weight gain. So all three are the side effects belong to the metazepine. But by blocking the H1 receptors, metazepine has the anti-anxiety effect. By blocking the 5-HT2C receptors, it causes the anti-anxiety, antidepressants, and weight gain as a side effect. So by blocking the H1 receptors and 5-HT2C receptors, it causes increase in the appetite and weight gain. By blocking the 5-HT2A receptors, metazepine causes antidepressant, anti-anxiety effect, and sleep restoring effects. But by blocking the 5-HT2A receptors, it has the advantage in the form of it does not cause any sexual dysfunction. So remember, sexual dysfunction mostly occurs with the SSRI group of the drugs and sometimes SNRI group of the drugs, but metazepine does not cause any sexual dysfunction. By blocking these 5-HT3 receptors, metazepine reduces the vomiting. So metazepine is an anti-vomiting drug, whereas SSRI group of drugs are vomitogenic drugs. By blocking the alpha-2 receptors, it increases the level of the norepinephrine and serotonin. The main therapeutic action of the metazepine is due to by blocking these alpha-2 receptors. How this blockage of the alpha-2 receptors increases the level of norepinephrine and serotonin, we will see in next slides. As we know that there are two kinds of the alpha receptors. One is the alpha-1 receptor and second one is the alpha 2 receptors. Likewise, there are the lots of the serotonin receptors like 5-HT1A receptor, 5-HT1B receptor, 5-HT1D receptor, 5-HT2A receptor, 2C receptors, 5-HT3 receptors, 5-HT4, 5, 7, 6 receptors. But because metazepine acts on the alpha 2 receptors and 5-HT2C and 5-HT2A receptors, so I will here focus on the alpha 2 receptors and the 5-HT2C and 5-HT2A receptors. Alpha 2 receptors are of two types, one is the autoreceptors and second one is the heteroreceptors. Autoreceptors means they locate on the norepinephrine neurons and on locus coeruleus, whereas heteroreceptors means they locate on the neurons other than the norepinephrine neurons like serotonergic neurons. Like alpha 2 receptors, 5-HT2C receptors and 5-HT2A receptors are also autoreceptors and heteroreceptors. Autoreceptors means they are located on the 5-HT neurons, whereas heteroreceptors means they are found on the neurons other than the serotonergic neurons. So what is the function of the alpha 2 receptors and the 5-HT2C and 2 receptors? We will see it in the next slide. Remember, alpha 1 receptors are the excitatory in nature, whereas alpha 2 receptors are inhibitory in nature, whether they are the autoreceptors or heteroreceptors. So, autoreceptor alpha 1 receptors increase the level of the norepinephrine, whereas alpha 1 heteroreceptors increase the serotonin level. Likewise, alpha 2 receptors, which are the autoreceptors, decreases the level of the norepinephrine, whereas alpha 2 heteroreceptors decrease the level of the serotonin. Like the alpha 1 and alpha 2 receptors, serotonergic 5-HT1A receptors and 5-HT2A receptors and 5-HT2C receptors are also excitatory or inhibitory in nature. Especially a 5-HT1A receptor act as a both inhibitory as well as the excitatory. So 5-HT1A autoreceptors, because they are the inhibitory, they will decrease the secretion of the serotonin. These 5-HT2A and 5-HT2C receptors are inhibitory in nature, so they will block the secretion of the norepinephrine and dopamine. So from our table, we can say that the alpha 2 receptors blockage leads to the SNDI, that is serotonergic norepinephrine disinhibition, whereas 5-HT2A blocker and 5-HT2C blockers are the NDDI, that is norepinephrine dopamine disinhibitors. So remember, alpha 2 receptor blocker are the SNDI, whereas 5-HT2A and 5-HT2C blockers are the NDDI. Why? Because we know that the alpha 2 receptors are inhibitory in nature. They will decrease the level of the serotonin as well as the norepinephrine if they are the heteroreceptors. And likewise, 5-HT2A and 5-HT2C receptors, which are also inhibitory in nature, they will decrease the level of the norepinephrine and dopamine if they are the heteroreceptors. So blockage of the alpha 2 receptors will increase the level of the serotonin and norepinephrine, and blockage of the 5-HT2A and 5-HT2C, especially the 5-HT2C receptors, cause the NDDI effect, that is norepinephrine and dopamine level increase. 5-HT1A agonist is also a DDI, like that is dopamine disinhibitor, that is it will increase the level of the dopamine. And likewise, if we block the alpha 1 receptors, which leads to the decreased activity of the serotonin norepinephrine. Why? Because we know that the alpha 1 receptors are the stimulatory in nature, that is they will increase the level of the serotonin and norepinephrine. By blocking the alpha 1 receptors, we will decrease the level of the serotonin and norepinephrine. Now coming to the pharmacokinetic properties of the metazepine. Metazepine has a half-life of 20 to 14 hours. The presence of the food in the stomach has a minimal effect on both the rate and the extent of the absorption, and so does not require a dose adjustment whether metazepine is taken with the food or without food. Metazepine is metabolized by the CYP1A2, 3A4 and 2D6 enzymes. No inhibition of the metabolism of other drugs was found because metazepine does not inhibit these enzymes. So, no significant drug-drug interaction is found with metazepine. So, hence, drug of choice is metazepine in case of as an add-on therapy to antidepressants. Now, coming to the indications or uses of the metazepine. Metazepine is only approved for the major depressive disorders, and as we know that the metazepine has certain advantages in the form of it causes the hypersomnolence but it does not cause the insomnia. It increases the appetite and weight. So depression having the insomnia or decrease in the appetite, weight, or having the psychomotor abnormalities, in these cases metazepine is used as a treatment. So if patient is having the depression with insomnia, in that case metazepine can be used. In melancholic depression, we know that in melancholic depression patient has the psychomotor abnormalities as well as reduce in the diet and the appetite. So in this case metazepine may be very useful. Metazepine can be used in the depression. In cancer patients, metazepine is also a drug of choice as add-on therapy to other antidepressants because we know that the metazepine is although it is a weak antidepressant but it doesn't have any drug side effects. Also metazepine can be used in depressive patients who are taking the SSRI group of the drugs. Why? Because SSRI group of the drugs causes the insomnia, GI disturbances and the sexual dysfunctions, whereas metazepine can counteract these side effects because we know that the metazepine does not cause the insomnia, it doesn't have the GI side effects and it does not cause the sexual dysfunction. So as add-on therapy, metazepine can be used with other SSRI group of the drugs. A combination of the venlafaxine with metazepine is called the California rocket fuel. Now coming to the other off-label uses of the metazepine. Metazepine can be used in the anxiety disorders like GAD, panic disorder, social anxiety disorder. Metazepine can also be used in schizophrenia, especially with the negative or catatonic symptoms. Metazepine also can be used in patients having the insomnia. But remember, these are the off-label uses of the metazepine. That is, metazepine has not been approved for these indications. Before administering the metazepine, we have to investigate the lipid profile, especially in some susceptible population. While lipid profile is investigated, I will give answer of this question after some time. Now coming to the formulation, doses and administration of the metazepine. Metazepine is available as a scored tablet and the orally disintegrated tablet form. The doses of the metazepine are 15 mg, 30 mg and 45 mg. But in certain countries, metazepine are used up to the 60 mg. Dosage ranges of the metazepine are the 15 to 45 mg. Starting dose of the metazepine is 15 mg 1 HS. Metazepine is given in night because it has the hypersomnolence as a side effect. Dose is increased by the 15 mg after 1 week. Remember, reduced doses of metazepine are required in elderly patients or persons with the renal or hepatic insufficiency. Now coming to the precautions and side effects associated with the metazepine. Here I want to draw your attention. Remember, whenever we read the side effects of any drug, especially the psychotropic drugs, we have to keep in mind we have to pay attention on certain organs. So first and foremost important organ is the central nervous system because most of the psychotropics are act on the central nervous system. Second organ is the gastrointestinal tract because most of the psychotropic drugs are used by the oral routes. Third one is as they are metabolized in the liver, so we have to pay attention on the function of the liver. Fourth one is the cardiovascular because cardiovasculars are the vital organ. We have also investigated the hematological functions. We have to assess the hematological functions and also neuromuscular and endocrinological functions. Here are the list of the adverse effects associated with the metazepine. The most common side effect of the metazapine is the hypersomnia. This is the most common side effect. It occurs in the 50% of the patients, but it is transient in nature. It will remit within 1 week. Other central nervous system related side effect is the giddiness. So driving and using machine are avoided. This advice is given to every patient who are on the metazapine. Second most common side effect is the GIT related. It causes the increase in the appetite and weight gain. Metazapine's anticholinergic side effect causes the dry mouth and the constipation. Metazapine increases the cholesterol level up to 20% in 15% of the patients. It also increases the triglyceride level up to 500 mg per deciliter in 6% of the patients. That's why metazapine, before administration of the metazapine, lipid profile is checked. Metazepine can cause the increased level of the ALT in 2% of the population. Metazepine has the myalgic side effects. It may disturb your dreams. Metazepine and hematological side effect is the reversible neutropenia. It is seen only in the 0.3% of the patient, and also it is seen only in the susceptible population, and this side effect was seen pre-marketing level. However, if any patient on metazapine have fever, chills, sore throat, mucous membrane ulcer or other signs of infection, immediately stop this drug. Metazapine's cardiovascular side effect causes the postural hypotension. Why postural hypotension occur? We know that the metazapine has the alpha blocker property. Now coming to the pregnancy and the metazapine. However, no data available on the fetal development, so still metazapine should be used with caution. Remember, SSRI group of drugs are very safe in case of the pregnancy. In case of the lactating mother, as metazapine is excreted in the breast milk, hence metazapine not to be taken by the lactating mother. So this is all about the metazapine. Thank you so much for watching my YouTube video. If you have any query, you may comment on the comment box. I will try to solve it. Thank you so much.